Pilar. Le voy a dar espacio a la doctora Mary Samplaski, que viene de Los Ángeles. Ayer la habíamos presentado. La doctora tiene bastante experiencia en el tema de fertilidad masculina y está principalmente dedicada a ver pacientes con infertilidad. Doctora Samplaski.
I'd like to thank the Society once again for having me. The AUA wanted me to give this same presentation twice, so they must be sort of really believing in male infertility. So these recommendations are based on the 2010 AUA Best Practice Statement. And how big of a problem is male infertility? So infertility is defined as having unprotected intercourse for 1 year. It affects 15% of couples who are trying to achieve a pregnancy. 20% of these will have a pure male factor, and an additional 30 to 40% will have both a male and a female component. So in general, approximately 50% of couples will have some type of a male component for their subfertility. With the advent of assisted reproductive technologies, such as in vitro fertilization, the question of why is a male evaluation necessary does come up quite commonly. And in my mind, there's great reasons for why we should still be evaluating these men. Number one, in some men, we will be able to detect a reversible pathology so that these couples can have a baby on their own, which in general is what most couples want. Like, they don't want to need some type of assistance. So sometimes you'll find that the guy has low testosterone, which can be associated with other issues down the road. A varicocele, which may affect his testosterone or cause discomfort. And in some men, you're not going to avoid the need for assisted reproductive technology, but we may be providing them with better sperm, so healthier sperm, which will then go on to fertilize better and have lower miscarriage rates and provide healthier babies. And then in some men, you just detect lifestyle factors. So, if I can get a couple of men to stop smoking, to me, that's a good thing. Or correct DNA fragmentation to provide the healthier sperm. And then finally, every once in a while, you'll find a guy who you detect a testicular tumor or diabetes or something underlying that could be a real threat to their health long term. So there was actually a study by Bob Oates that looked at what do we find in men that are evaluated. So these were men who were referred by the reproductive gynecology community for a male factor evaluation. And what they found was that over half of these men had some type of a treatable pathology. So whether it was low testosterone or varicocele or vasoagenesis, a lot of these men had something that was treatable. So when I see these men that present for fertility evaluation, the history is very important. I always ask about how long have they been trying, any history of cancer, chemo, radiation, undescended testicles. I always ask about a history of asthma or CF, and I'm surprised at the number of men who, if they say they have some type of asthma, don't have a VAS. So that can be sort of a marker for an underlying vasoagenesis. Chronic infections, even mumps that caused, and mumps orchitis, cigarettes, marijuana, hot tubs. There's a lot of people who don't realize that sitting in a hot tub can cause a decline in their sperm counts. Medications. So I'm amazed at the number of men, and some of this is the fact that my practice is in Los Angeles, but the number of men who come to my clinic on testosterone replacement, either shots or gels, who don't realize that that can decrease their sperm counts. And finally, I ask about the female history. So how old is she? Has she had a female evaluation? Does she ovulate? Does she know when she ovulates? And every once in a while, somebody will say something along the lines of that their partner has not had a period in several months and that they don't know why. So the history is important. On exam, there's always the general assessment. Does the male seem to be androgenized? Does he have facial hair and deepening of the voice? Does he appear to have any gynecomastia? I always look for abdominal scars. On the GU exam, obviously the testicular size and testicular consistency is important. Does he have vasa? Does he have a varicocele? Is his epididymis tender? Does he have scars on his groin? And then if there's any concern for Kallmann syndrome, so if the guy says, oh, I really have never had a good sense of smell, I'll usually listen to his heart and see if it seems to be beating on the left side of his chest. And if there's any concern for a prolactin issue, then we check for visual field defects. And usually what that is sort of breast tenderness or nipple discharge. Those are usually the indicators to me. So looking at the semen analysis, the most up-to-date criteria are from 2010. The volume that we're looking for is 1.5 cc's with a concentration of 15 million. The motility we like to be more than 40%, morphology more than 4%, and you'll note that the morphology is a very low number, and so I always end up telling these couples that most sperm do not look normal, they don't look perfect. But the interesting thing is that abnormal morphology does not consistently seem to correlate with any reproductive outcomes. So studies looking at intrauterine insemination and IVF success rates some have shown that poor morphology is actually positively correlated with reproductive outcomes. Leukocytes, these are obviously bad for semen to have white cells, so we like that to be less than 1 million. Whenever the volume or the count is low, I always ask the man, how long of a duration of abstinence did you have? So it needs to be at least 2 days. I sort of prefer 3 or 4 days, but a minimum of 2 days. We always confirm with a second sample because sometimes the variation between the two samples can be significant. And if a sample comes back for no sperm, this is a devastating diagnosis for the men, so we always confirm with a second semen analysis, but we always look at the lab report to confirm that they did centrifuge the sample and that it wasn't just an initial survey. So any man who has less than 10 million sperm gets an FSH and a total and free testosterone. The other men who should have the initial laboratory evaluation include men who have abnormal sexual function. So if a guy complains of erectile dysfunction or ejaculatory dysfunction, or if they have other findings of an endocrinopathy. So if they do appear to not be androgenized, or if they're complaining of nipple discharge. If that initial testing comes back abnormal with either an elevated FSH or a low testosterone, then we repeat the FSH and testosterone and also add on a prolactin and an estradiol and an LH. So just a brief review of the hypothalamic pituitary gonadal axis. The hypothalamus releases GnRH, which then stimulates the pituitary to release FSH. FSH stimulates the seminiferous tubules to secrete sperm, which then feed back via inhibin. The pituitary also releases LH, which stimulates the Leydig cells to produce testosterone, which then feeds back to the hypothalamus and pituitary. Some testosterone is always converted to estrogen, and the estrogen also feeds back on both the hypothalamus and the pituitary. So anyone who has less than 5 million sperm gets a karyotype and a Y chromosome microdeletion. The karyotype is looking for both Klinefelters and also Robertsonian translocations. Anyone who you only feel one VAS gets CF testing, and I always send CF testing on both the patient and the partner, just because it can have implications for the offspring if both of them are carriers. And even if the CF testing comes back negative, if the male does not have a vasa that's palpable, I consider him a carrier, because we know that there's mutations that are not necessarily detected on the standard assay. Anyone who has less than 5 million sperm also gets a Y chromosome microdeletion testing. What this is that there's 3 regions on the Y chromosome that detect for proteins that are involved in sperm production. AZF A and B abnormalities have never been found to have sperm at either ejaculate or at surgical sperm retrieval, but AZF-C microdeletions have. It's important to note that this Y chromosome will be passed on to any male offspring. Therefore, this may actually be an indication for selecting for female embryos if the couple undergoes IVF, but the couple just needs to know that this will be passed along to any male embryos. In any patient in whom any of these are abnormal, I send them for genetic counseling, and patients actually find that quite helpful. This is just a sort of overview of some of the conditions that we might find. I'm happy to provide the slides to anybody who would like them. So when to check a post-ejaculate urine. So these are men who I'm concerned about some type of retrograde ejaculation. So this might be after someone has had an RPLND for testis cancer or some type of colon cancer surgery. And then you have people that retrograde idiopathically. So those would be people who, when they have the sensation of orgasm, but nothing comes out. And sometimes they will also report that the first urine after they ejaculate is cloudy. So whenever somebody has less than 1 cc, I think about that. But it's also amazing the number of people who just miss the cup or feel like making a sample in a lab or in a hospital is not natural, which is totally understandable. So if the volume's low, the things I think about are, did they miss a cup, or is there some kind of collection issue? Is it an inadequate time of abstinence, or are they retrograding? And then obviously Flomax and tamsulosin and other alpha blockers can do this, as well as 5-alpha reductase inhibitors. In terms of imaging, so whenever I'm concerned that there's some type of ejaculatory duct obstruction, then I would get a transrectal ultrasound. Sometimes you can actually feel dilated seminal vesicles on physical exam. On transrectal ultrasound, you're looking for seminal vesicles that are more than 2 centimeters in size. Oftentimes, if somebody is obstructed, they will complain with pain with ejaculation because they're sort of ejaculating against either a scarred area or against a stone, and the ejaculate will be more acidic. This can be treated either with aspirating directly from the dilated seminal vesicle or by doing a transurethral resection to actually relieve the obstruction. When to get a scrotal ultrasound, we do not always get scrotal ultrasounds for varicocele because according to the American Society of Reproductive Medicine guidelines, the only varicoceles that should be fixed are the ones that are clinically palpable. The reasons that we do get an ultrasound is if there's any concern for anything on the exam. So if you feel like there might be a mass or you feel like it's a difficult exam, guys with undescended testicles have a higher risk of testicular tumors. So those are men who should have an ultrasound. If there's ambiguous findings on your exam, it's a relatively non-invasive test and they're not getting irradiated, but you should not do it for varicoceles. And finally, the role of testicular biopsy. So this is a very important paper by Craig Niederberger, who basically, this has changed the patients in whom we biopsy. So anyone who has an FSH of less than 7.6, so relatively low, and a testicular length more than 4.3 centimeters, so essentially a normal-sized testicle, you should not need to biopsy them because 96% of these guys are obstructed. So while in the past these are men who we would do a clinic biopsy on, based purely on this paper, now we would take these guys for either reconstructive surgery or a testicular aspiration to obtain sperm to use with an IVF cycle. And just quickly, the 3 main modalities of assisted reproductive technology. The first one is intrauterine insemination. For this one, you need approximately 5 million swimming sperm. Essentially, the man makes a sample into a cup. The lab spins the sample down, and you obtain a concentrated pellet of sperm. It's maybe about half a cc. When the female is ovulating, this is injected using an angiocath past her cervix and into her uterus. So the sperm actually swim toward the egg. And sometimes the reproductive gynecologist will actually do this stimulated so that the female is releasing more than one egg at the time of the insemination. IVF, this is essentially for very low numbers of sperm, less than 5 million. The man makes a sample. The female receives medication so that her ovaries produce more eggs. These eggs are actually taken out of her body and placed into a dish. The sperm swim toward the egg, but it's in a dish. It's not in the body. The resultant embryos grow for 3 to 5 days and then are placed back into the female, and extra embryos are frozen. The one step above IVF is ICSI, and this is for very low numbers of sperm. So the sperm are actually injected into the egg, so they don't have to swim anywhere. They just get injected directly into the egg. And this is usually done where there's so few numbers of sperm that you really can't leave anything to chance. So I'd like to thank everyone for listening. I practice in Los Angeles, and if anyone finds himself in the area, I know we get a lot of visitors at my hospital, and we'd love to see you. Thank you.